His awards include the Sidney Ingbar Distinguished Award from the Endocrine Society, Fellow of the American College of Physicians, the Robert Petersdorf Teaching Award, and appointed member of the Scientific Advisory Board for the Partnership for Clean Competition. Dr. Matsumoto is currently a member of the editorial board for the Journal of Clinical Endocrinology and Metabolism, editor for the up-to-date section on male reproductive endocrinology, and member of faculty of 1000 Biology. His biography is equally impressive with well over 500 articles, book chapters, reviews, abstracts, and presentations, and he's here to give us his presentation for Grand Rounds. Thank you.
Thanks, Amanda. So here are my disclosures. I think you probably have them written down somewhere. And I'd like to start out with a picture of myself back in the days I was a house staff officer here as a poster child for an aging man. So here I am as I think a first-year resident. It seems like Dr. Turk and Dr. Wallace haven't aged, but I think you'll notice a substantial difference in the way I look compared to when I was a resident here. The game plan today is I think I'm going to try something a little bit different. Rather than concentrating clearly on the clinical science or clearly on the clinical practice, I'm going to do a little bit of both and start out with the clinical science. And because at this point in time, the evidence base that clinical science gives us to inform clinical practice is inadequate, I wanted to make sure that we talked about some of the practical clinical issues related to treatment of older men with testosterone, and really what to do in the meantime awaiting outcome studies and to avoid some pitfalls that I think are occurring more and more frequently, hopefully not at this medical center, but certainly around anti-aging clinics all around the United States and in Europe. This is occurring quite frequently, and the pitfalls, I think, are quite great. And so hopefully the academic community will not fall into this. Now, I'm not going to go over this. As the typical endocrinologist will go over the hypothalamic pituitary testicular axis. I only wanted to point out that the hormone we're going to talk about is testosterone, which will be abbreviated as T, and that it has basically actions on just about every body tissue in man. The most common and the most prominent effects are shown here in this box, and I think we'll go over some of these today. The testosterone is produced by the testis. It's controlled by the brain and the pituitary by hormones LH and FSH, luteinizing hormone, follicle stimulating hormone. I think you know this, and there's a negative feedback loop. But the one thing I wanted to put up front right away is the fact that because the brain controls the testis, I guess we always knew that anyway, but the brain does control the testis. Because that happens, the whole axis and testosterone production is regulated and can be negatively influenced by illness, by medications, and by various states of nutrition, undernutrition and overnutrition, obesity. So I think I'd like to put that up front. Let's start out with multiple studies have shown that in man, there's a gradual and progressive decline in serum testosterone levels. Not like in menopause in women where there's a more precipitous drop at the time of menopause and in middle to late age that occurs in women and estrogens. That does not occur in men. There's a gradual decline, unfortunately beginning in your 30s. Keep that in mind. And then, but not so dramatic. And the proportion of individuals that drop below the normal range increases as a function of age. Now, associated with decline in testosterone are changes in the body that are really could be related to low testosterone. And the most obvious is really shown in a slide that I showed the last time I talked at Grand Rounds of the 1936 UW Olympic gold medal crew. Okay, shown here when they won the gold medal. In those days, colleges competed, not a national team. And shown here is a 50-year reunion of the same group of individuals minus one. And you can see pretty obviously there's a change in sort of morphology. The body type has really changed quite a bit, dramatically. And if you look at longitudinal studies here in a composite done by Forbes of all the longitudinal studies, as well as a few cross-sectional ones shown in it, And so this is sort of a meta graph in the sense of all these studies. You'll see that as a function of age, fat mass goes up, shown here in the blue, and lean body mass, as well as muscle mass, the lean body mass component of muscle mass also goes down, and muscle strength goes down. And so you could argue, well, no, that's because they're ill and they're not working out and they're not having enough exercise and nutrition is a problem and so on and so forth. But the strength decline occurs even in elite athletes, shown here in Olympic weightlifting performance as a function of age. In masters athletes who are well-trained, well-conditioned, eating correctly, maybe a little anabolic steroids thrown in on the side, but that aside, if you normalize their performance to age 30, there's a progressive decline as a function of age. So if you summarize all of these, in addition to the decrease in muscle mass and strength and increase in fat mass that's associated with aging, there's a decrease in bone mineral density, as you know, even in men, and osteoporosis does occur in men, and there's an increasing risk of fractures as you get older, as well as a decline in sexual function, energy, mood, and cognitive function. And all of these age-related changes coincide with an age-related decline in testosterone levels. And also, in younger hypogonadal men, that is, individuals with disorders of the testis or the pituitary or hypothalamus that have low testosterone levels, a lot of these same changes occur in that population, and when you treat in hypogonadal men with testosterone, these things improve. And so a natural question that you would ask is, does a decline in testosterone with aging associated with these age-associated changes in your body? Unfortunately, a lot of people have taken just this and used it as a rationale for treating older men with testosterone. I'm afraid that's really, the science does not support that at this point in time. There have been small studies, some of which we participated in, and I'm going to show you some that Lisa Tenover did that we participated in, and then summarize some of the whole body of evidence that we have with these short-term trials. So Lisa did a randomized double-blind placebo-controlled trial. She was a former geriatrics fellow here, went to Emory and did these studies in Emory. A 3-year randomized double-blind placebo-controlled trial of testosterone administration versus placebo. And shown here in older men with low to low normal testosterone levels. Shown here are the changes in lean mass and fat mass that occurred over the period of 3 years. In magenta is the testosterone-treated group, and in the yellow is the placebo-treated group. And you can see here that over the course of 3 years is an increase in lean mass of about 4.5 kilos, and a comparable decline in fat mass with testosterone relative to placebo. In addition, there was an increase in grip strength in these individuals over the course of 3 years, and an increase in physical performance. As well, there was an increase in in lumbar spine bone mineral density, as well as hip bone mineral density. Now, I show you these because these are positive studies, but they're not all positive. And so if you look at the whole of the evidence base we have, I think the conclusion that you can reach is that there's a very heterogeneous group of studies here. They're generally a short term, at most 3 years. They're controlled trials, but there are small numbers of generally healthy older men, really recruited to be relatively healthy with low to low normal, some with testosterone levels in the normal range, in the low normal range. And then they use various types of testosterone and testosterone dosages. And so the replacement can get people up to normal levels, and some that didn't even quite get to normal levels. So with this heterogeneity, meta-analysis really, to me, doesn't make a whole lot of sense. There's too much heterogeneity here. But one thing that has actually been very consistent with most all of these studies is the improvement in lean mass and the decrease in fat mass, improvements in body composition. What's inconsistent, and what I showed you in the Lisa Tenover studies, is that there are inconsistent increases in muscle strength and performance and bone mineral density, as well as in sexual function and cognitive function. The only short-term side effect, if you want to call it that, and some people would call it a benefit, is an increase in hematocrit, sometimes to high levels. And there have been no changes in lipid or prostate disease. We don't have long-term randomized controlled trials to assess clinical benefits and risk, unfortunately. What we'd like to know as clinicians are, what is the effect of testosterone long-term on frailty, prevention of fractures, cardiovascular disease, and prostate cancer? Don't have that. So as a result of that, and about the end of 1990s, the NIH and the VA put out a request for proposals of anabolic treatments for geriatric conditions. And Glenn Cunningham at Baylor and myself put together a group of testosterone mavens and experts, and basically and designed a study called Esteem. That would be efficacy and safety of testosterone in elderly men study. And presented it in 2001 after a couple of revisions. This was a randomized double-blind placebo-controlled trial of 6 weeks duration using testosterone gel in approximately 6,000 individuals over the age of 65 with low testosterone. And the primary outcome, because at the time we had Lisa 10-over studies and other studies that suggested that bone mineral density improved, the primary outcome at that time was fractures. Incident fractures, but we had enough numbers as well as duration of time that we would be able to comment on incident prostate cancer and cardiovascular events. The total budget was about 100 million, with another 30 million thrown in for some of the sub-studies. And it was reviewed very intensively both by the VA and the NIH, and then combined twice, and it actually was approved. In fact, it was approved with quite a good priority score, but there wasn't enough money to pay for it. Okay, so they went around and shopped it to various NIH institutes, and the NHLBI and NIDDK was certainly interested. But what I have here is that timing is everything. What happened at the NCI, the National Cancer Institute, is that the newly appointed director, who was a prostate cancer urologist who had prostate cancer, whose father died of prostate cancer, really was concerned about the prostate cancer risk and really questioned the ethics of actually treating somebody in a clinical trial of older men with testosterone, even though there is no evidence to this date of what the relationship between testosterone and prostate cancer is. At the same time, another bad timing issue was that the Women's Health Initiative was stopped right at that time. Okay. At least the combined hormone replacement therapy arm of that was stopped in July of 2002. And so even though the study was approved, it was actually held up for funding and actually generated an actual Institute of Medicine study and committee to review testosterone studies. And the Institute of Medicine concluded from the review that, in fact, what needed to happen were short-term efficacy trials first before long-term outcome studies were performed. And that we needed to be especially cautious about prostate cancer, even though, again, there really was no evidence that there's any relationship between that and testosterone treatment. And they also suggested, because the epidemiology of hypogonadism or low testosterone and testosterone treatment was not known, they suggested that there needed to be more epidemiology before we launched into the outcome study. So actually we skipped many, many years, but so the Esteem group, the group that initially designed and proposed the Esteem study, got together, competed successfully for a planning grant, reviewed twice, wrote another proposal for a study of testosterone treatment for a year, which was also reviewed twice, and then finally got approved, and then finally got funded after a budget cut of 25%. In 2009. Okay, so what we have here is an example of how politics and how time and timing affect clinical research over the course of an investigator's lifetime. Okay, so in 2009, we luckily at least got something started in terms of a randomized trial called the testosterone trial, or the T trial, and it has been going along. It's a randomized double-blind placebo-controlled trial of testosterone versus placebo, 1 year of exposure, again, short-term exposure in 800 men above the age of 65. But the thing that is different and what we try to do in this study is to try to address some of the limitations of the previous evidence base that I showed you at the beginning of this talk, and try to make sure that these are individuals that had clinical signs and symptoms that could be related to androgen deficiency. They had unequivocally low testosterone levels and conservatively very low testosterone levels, less than 275, on 2 occasions. And not only that, it was a coordinated trial. It's not just one study looking at one outcome, it's 7 coordinated studies. And it has the virtue of allowing individuals coming in with the same criteria and then going into various components or various studies. The primary outcomes were physical function, sexual function, and vitality, and cognitive function had to be pushed to a secondary outcome because of budget considerations, but that is also being studied. Anemia, cardiovascular, cardiovascular disease, that is plaque volume by CT angiography, bone mineral density by CT, quantitative CT, lumbar CT. Testosterone gel was used, and the other thing that we thought was very important is to adjust the dosage of testosterone so that we achieved throughout the entire 1-year exposure levels that are in the mid to high normal range. That's ongoing, and recruitment, thank goodness, is going to come to an end probably in a week. And so by another year or 2, year and a half, depending on how fast we can write this up after it's done, we might have some results to tell you about. So this grand round is a little bit premature, but at least there's a start, but not really good enough, in my estimation, to inform clinical practice at this point in time. So the Institute of Medicine also said there needed to be some epidemiology studies, and being at the VA and being associated with the University of Washington and the VA Epidemiology Center, we decided to at least try to add to the evidence base in terms of epidemiology studies. And so the initial study we did using the VA database and the regional VA database was done by Molly Shores, who demonstrated basically that in veterans with very low testosterone levels, less than 200 with the lower limit of normal being 280, there was an increased incident depression diagnosis in these individuals compared to individuals with normal testosterone levels over a period of 800 days. Subsequently, we actually demonstrated that individuals with consistently low testosterone levels had reduced survival compared to those with consistently normal testosterone levels, and those with some high, some low, some normal testosterone levels or inconsistent testosterone levels has a survival in between, somewhat of a dose response theory in this particular study. We thought that was pretty interesting. But a lot of epidemiology has happened in the last 10 years in this area. I'm sure you've noticed this in just about everybody's publishing these in their various databases. And even though they're inconsistent, I think there's more consistency than inconsistency, and that low testosterone has really been associated with a variety of clinical outcomes of great importance, like diabetes and cardiovascular disease and cardiovascular events, fractures, falls, all of those listed here, as well as all-cause mortality that we demonstrated. That has been demonstrated by others, as well as cardiovascular mortality. And so, the epidemiology now is there. Again, really addressing one of the Institute of Medicine's major concerns. So we do have observational data. Unfortunately, observational data doesn't tell us that testosterone treatment will help any of these conditions that low testosterone is associated with. And so if you really want to answer that for any outcome, let's say mortality, you need a large randomized controlled trial, which isn't going to happen, at least in my investigative lifetime, excuse me, I don't think. So what we decided to do was, again, take advantage of the VA database and ask a pharmacoepidemiological question of whether or not there's an association between testosterone treatment and usual clinical care and mortality. And we had the luxury of having an association with Nick Smith, who's in the Epidemiology Center at the VA, who is the pharmacoepidemiologist. About that. I am not a pharmacoepidemiologist, so let me just tell you that I can't answer all the detailed questions, but I can tell you that what we found and published was that testosterone treatment, in fact, was associated, okay, associated with a greater survival than in individuals with untreated low testosterone levels. And it's shown here. And it was a substantial difference in survival, okay? And all the pharmacoepidemiologic approaches to try to reduce potential confounding, sensitivity analyses, adjustment for comorbidities, propensity analysis, not quite instrumental variable analysis, but all of the things that you can do to try to make sure that we don't have potential confoundings were done in the same kind of relationship help. The problem is the major limitation with all pharmacoepidemiology studies, at least in my estimation, is that you can never really know whether you've accounted for all confounding variables, and potential selection bias is still there. Healthy user effect is a potential because maybe individuals get treated with testosterone versus not getting treated because they're healthier and they have less sex. Even though we tried to correct for that, maybe you can't really do that very effectively. The strength, though, the strength of these kinds of studies does tell us that clinical outcome, at least mortality in this instance, but clinical outcome in usual clinical care, the way that testosterone is being used in clinics in the VA population, albeit, that is actually probably it's not killing people, I don't think. The conclusion is really that it's not associated with an increase in mortality. I think we can say that. In order for the reversal of this particular study to show harm or decreased survival, it would take quite a bit of confounding to actually have that. I don't think, though, we can say that the study is can show a beneficial effect of testosterone on survival. And that's how I'm hoping things don't get misinterpreted, but have been misinterpreted with this kind of study, at least in the press and in the hands of individuals that like to prescribe testosterone. What it does, the other conclusion is that I think there's value in pharmacoepidemiology, and in fact, we've just been funded, along with 2 other sites, to actually look at the national VA database to do similar type studies of the effects of testosterone treatment and its association with various clinical adverse outcomes, as well as beneficial or efficacy type outcomes. So we'll have some more data over time. So I'm going to move a little bit now to the treatment, the clinical side. That's the state of the clinical science. And as you'll see, really doesn't justify kind of willy-nilly testosterone treatment of older people, right? I mean, and older men. The concept of treating older individuals with hormones, and particularly testicular hormones and testosterone that we're talking about today, really started back in the days of Brown-Séquard, who you know probably as a neurologist that described the spinal cord syndrome. But as he was getting older, shown here at age 72, I hope I look a little bit better than that at age 72. But at any rate, he was looking a little down and a little dirty there. And so he decided, because he was a good scientist, he just would ground up a bunch of testes from dogs and guinea pigs and start injecting himself. And lo and behold, he was rejuvenated. And the things that rejuvenated were strength and intellectual labor, but the other thing that I found in the actual paper, in the Lancet paper, was that it improved his expulsion of fecal matters. Now, that to me struck a chord, because we used to have the uniformly positive review of system, the stools glowing in the dark kind of thing. That really struck a chord to me and said, this is got to be a placebo effect, right? And in fact, it probably is, because aqueous extracts of steroids from a tissue can extract very little steroid. So there was very little testosterone in this particular extract. What's happened, though, in the modern generation is that we've had all these clinics pop up, these anti-aging clinics and these hormone treatment clinics that have, here's an example here of one ad in the internet, that have a whole bunch of claims of rejuvenating you with testosterone or human growth hormone is another topic. And a variety of herbs and a variety of types of medications. And not to use testosterone that's approved by the FDA, but to use bioequivalent testosterone formulations where you buy testosterone off the shelf and you compound it in a gel or a cream, and then you put it on people and without any quality control at this point in time. And so, this is the modern day version of Brown-Séquard, if you ask me. And there's not a consideration of who you treat, how you treat it. And what I'd like to point out is that it's not quite as simple as measuring a hormone that's low and then treat somebody and not monitor it. Because that's one thing that I think is a danger in all of this concept. It's much more complicated, and that's the one reason I wanted to spend the rest of the time talking about the clinical side of this condition. Also, there's an increasing prescription rate starting in the 2000s, actually starting before then, but right around 2000, 2001 is when testosterone gels became available, and you'll notice that since the gel has come on board, because of the convenience and the ease of applying these things, testosterone prescriptions have increased dramatically over time, and it's mostly the gel and to some extent the injections as well. So the problem with the concept of measure a hormone that's low, treat, is that if you just measure the hormone, testosterone levels will be low as a function of age increasingly as you get older, particularly as you get above the age of 75 or 70. And shown here are the proportions of individuals with low testosterone, or percentage of individuals with low testosterone in each decade, and for total testosterone in blue and in free testosterone in yellow. And so if you look at free testosterone, just about everybody above the age of 80 is going to have a low free testosterone. So, you know, if you just rely on a blood test, you're going to be treating everybody, you know, which doesn't make a whole lot of sense. That's not correct. And in fact, is privileged to be in part of the Endocrine Society Guidelines Committee, and we wanted to make sure we emphasize the fact, and you all know this as clinicians, that you don't treat a blood test value. You treat a patient, you treat a clinical condition that's associated maybe with a blood abnormality. In this instance, signs and symptoms of androgen deficiency should really be associated with low testosterone levels, but not only low testosterone levels, consistently low testosterone levels, and I'll tell you why that's important a little bit later. And in fact, the only right now indication would be unequivocal severe hypogonadism, the only indication for treating older men with testosterone. And then you might even have some pause. And so the complicated feature is the age in this issue, and in this particular area, and we'll talk about that. So if you look at the prevalence data for clinical hypogonadism or low testosterone associated with signs and symptoms, you'll notice that the percentages are much lower than what I showed you. It's not 30 to 40%, it's more like 2 to 9% as an overall percentage in men above the age of 50. And in all of these studies, including the ones that I was involved with, there's an increase in prevalence of clinical hypogonadism with age, and particularly above the age of 70. But the maximum it reaches is around 25%. It's not 80 to 90 or 100%. So here are the challenges in older men. Okay, the challenges really involve diagnosis and management. And so I really want to spend some time on this. Symptoms and signs of androgen deficiency are non-specific. And as you get older and as you get more comorbid disease or comorbid illness, there's a greater likelihood that a lot of the symptoms that you feel as you get older, and I feel as I get older, even though I don't have a lot of comorbid disease, by the way, not yet, that the symptoms that you feel may have more to do with the comorbidities than really androgen deficiency. But the complicating feature is that comorbidities can also lower testosterone. Okay, so we can't totally ignore this. But we should pay attention to that. Testosterone levels are quite variable and are assay dependent, and we'll talk about that because I think Dan Bankson is in the audience I saw around, and he knows this, and laboratory medicine, and I think we need to pay attention to this as clinicians. Again, there's no long-term trials, so how do we deal with this clinically? Let me try to give you a little sense of what I do sort of as I go through an evaluation of the diagnosis of an individual with hypogonadism that's older, as well as the treatment and management and monitoring. So diagnosis-wise, I think it's important to kind of go through a systematic approach of asking yourself as a clinician several questions. First of all, are there signs and symptoms present of androgen deficiency? That's generally where you'd start anyway. You wouldn't measure a hormone just as a routine. There's no evidence for screening routinely with testosterone, even though, again, some people do that. You start out with a clinical problem, you measure, and then you ask yourself, before you actually measure it, could there be something else in this patient that's causing these nonspecific symptoms and signs? And then before you measure testosterone, is there a recent illness or medication or malnutrition that can cause transient suppression of testosterone? As I showed in one of the first slides, illness, medications, nutritional state can actually lower testosterone. It can lower it transiently with recovery. There may be normalization. There's no need to treat with testosterone. No need to measure it at that point. And if testosterone is measured, is it consistently low? And when do I measure a free testosterone? And where is the problem? Is the problem primary in the testis, or is it secondary in the hypothalamus or the pituitary? And then if you get far enough along these questions, what's causing this? And are there any reversible causes of hypogonadism that might not need testosterone treatment? So the signs and symptoms of androgen deficiency are shown here, categorized as sexual, psychological, and physical. But as you'll see, you know, they're really nonspecific. There are multiple causes, potential causes of these symptoms. Even the sexual ones that you see here could be due to other conditions, could be due to some medication, so on. So I think it's very important to ask, before you attribute these signs and symptoms to hypogonadism, it's very important to ask, could there be something else causing these symptoms? Depression, as you get older, is increasing, particularly minor depression or dysthymia, as well as, to some extent, major depression. But depression can mimic a lot of these symptoms and signs that we saw in the previous slides. Medications can do that. Starting a new beta blocker, particularly at a high dose, can cause some energy problems and can cause some of these symptoms. A lot of antihypertensives can cause some sexual dysfunction. So I think you need to consider those, as well as comorbid illnesses, other comorbid illnesses that can contribute to the way somebody feels. These are all nonspecific symptoms. As well, you need to consider, before you measure testosterone, the fact that a recent acute illness or surgery or medications, particularly glucocorticoids or opioids, let's say used for acute pain. If the testosterone happened to be measured at the time somebody is taking a little bit of morphine for post-op pain, you know, that is going to be a low testosterone that's probably associated with that and would recover after a period of time and be coming off of opioids. Again, malnutrition can also cause transiently low testosterone. One slide I'd like to spend a little time on, and that we've contributed some literature on, is this issue of variability in measurements. You need to know your laboratory, and then you need to, in order to trust the measurements that you make on a clinical, in the clinic, you need to know that it's a reliable assay. Okay, I'm sorry to say that. That's probably true for every test that you order. I know you can't do that. But you need to rely on your laboratory medicine folks to have good assays. Because, number one, there's a lot of assay variability. So what I find very shocking in this day and age is that if you send the same sample around to different labs using different assays, the same sample, the reported measured level is anywhere from 160 to 508. It could be very low, slightly low, or very normal, okay, depending on what assay is used. And so I think you need to accept the fact that there is this variability, and as a result of that, I think this has primarily occurred, and I know Dan's in the audience, but my personal feeling is that's occurred because the quality control of these assays has basically been focused on reproducibility. As long as you're reproducibly getting the same value in a quality control sample, you can pass the muster of accreditation. And it hasn't been accuracy-based. And so the CDC now has a lot of experience with accuracy-based quality control and standardization for things like hemoglobin A1C and cholesterol and things that we use in the clinic all the time, has now taken on that testosterone as an important area to do standardization, and has now a program that we participate in that is standardized with an accuracy-based quality control sample. The other thing to keep in mind is that there's a lot of day-to-day variability in testosterone as well. This is biological variability. So if you measure testosterone one day, it may be 30% different on another day. And to put it in realistic terms, if you get a hypogonadal, slightly hypogonadal or low value on one day, the next time you measure it several days later, it could be normal. So I think you need to do more than one value in order to get a sense of where that individual actually lies. There's also circadian variability. Testosterones are higher in the morning. Fasting levels are higher as well, but those aren't as significant a variability as these other two. Finally, in terms of testosterone measurements, you have to accept that in some instances, the free testosterone level, which is only 1 to 2% of circulating testosterone, is unbound to these serum proteins, and the total testosterone measures all of these, bound and unbound. That if you have abnormalities of SHBG, sex hormone binding globulin, which is the main binding protein that binds testosterone and actually doesn't allow it to be biologically active, you may have situations where total testosterone levels are high or low, but free testosterones are completely normal. And the list of things that can cause this are quite common. We've seen, particularly in like a VA population or a population that has high comorbidity. But the two things that I think are the major causes of abnormalities of SHBG and as a result total testosterone are obesity and age itself, and in opposite directions. And so we looked at the last 3,600 testosterone panels that were done that provided us with total and free testosterone levels, and total is plotted here against free testosterone. And so everything on the left-hand side of this line, this vertical line here, is low in terms of total testosterone, and everything on the top of this is normal free testosterone and low free testosterone. So you see, what you see here is that individuals that have low total testosterone, 60% of those individuals will have normal free testosterone levels in this population of veterans with high comorbidity. So in this population, you could argue that, in fact, you should be measuring free testosterone more frequently than in other populations maybe that don't have potential abnormalities in sex hormone binding globulin. Moving on to why is it important to, you get this question all the time, why is it important to measure LH and FSH? Why is it important to measure pituitary hormones? And there's lots of reasons, but the major reason I just put up here is that you want to diagnose somebody with secondary hypogonadism. You want to diagnose somebody that might have a pituitary or hypothalamic reason for having low testosterone. Because one of the causes is pituitary tumor or infiltrative disease, and those individuals are managed much differently and without necessarily differently in terms of hormone replacement, and in fact may need surgery or something like that. It's uncommon. It occurs a little bit more commonly in older individuals, but it's uncommon. I think more common is the fact that secondary hypogonadism in an older population can often be reversible. And the reversible causes are shown here. And these are things that are pretty common, particularly these last three that seem to come recurringly are on all of my slides, right? The illness, the drugs, and malnutrition. But even, morbid obesity, which is much more common, obstructive apnea and hyperprolactinemia could be treatable independent of treating an individual with testosterone. So shown here is an example of what happens when you bypass a morbidly obese population, starting out at a BMI of 48 and getting to 32 after 12 months of a bypass surgery, and what happens to testosterone levels on top, beginning in the low area and then becoming normal as a function of time after bypass surgery. So if you treated this individual here, and left him on testosterone for the rest of his life, if compared to the individual that didn't get treated, you might be treating somebody that in fact has normal testosterone. So treatment-wise, we're doing well. Treatment-wise and monitoring. So the questions, once the diagnosis is established, I think as a clinician, you need to ask yourself, do I want to treat with testosterone? If I want to treat with testosterone, what formulation should I use? And what monitoring is appropriate? So the major decision in terms of treatment with testosterone, I think, from a clinical standpoint, from a clinician standpoint, is the severity of the problem, right? I mean, if somebody has classic hypogonadism, has lost all his body hair, male body hair, has got all the symptoms of androgen deficiency, is weak, and is not functional, and he's, and there's, good etiology for it, which we'll get to, then you would probably consider treatment more than not treatment. But an individual that just comes in that's a little fat, that's got just erectile dysfunction and nothing else, who's pretty healthy otherwise, you may be a little bit more reserved about treatment. Comorbid illness and medications, again, comes up. I won't belabor that. What I think you should keep in mind, and what strikes me as being quite important and should be always considered, and really a no-brainer, is the patient-specific goal that you're trying to accomplish. And what I'm impressed with in the older population is that sex isn't always the goal. Okay, it may be function. It may be quality of life in terms of energy and motivation and activity and those kinds of things. Okay, so it's not always sex. Okay. The other thing you should consider is that active prostate cancer and male breast cancer is an absolute contraindication, at least at this point in time, for testosterone treatment. And so when it comes down to considering treatment, you need to weigh the benefits and the risks. And the benefits and the risks, as we've alluded to in the previous slides, are based on short-term efficacy studies in older men. And those are listed here in terms of the benefits. The thing I like to point out on this slide are the potential risks. I think the risk of erythrocytosis in an older population is greater than a younger population and is substantial. And the theoretical, underlying theoretical risk of having too high a hematocrit or blood count is, excuse me, is the fact that viscosity goes up with increasing hematocrit, and that potentially in somebody with underlying vascular disease that may contribute to their vascular events or vascular outcomes. The other risk I have in here, which isn't often quoted as a risk, is the risk of prostate biopsy. And it's not prostate cancer, but because you get more prostate biopsies, there may be more diagnoses of prostate cancer. So that is a consequence of over-monitoring and possibly going to prostate biopsy. That is a risk. And going down the road, as we've discussed a lot more recently about screening PSAs as a result, causing more biopsies, causing more diagnoses, causing more concern of prostate cancer. Unneeded concern, because most prostate cancer is low risk, low grade disease. So that I think is a real risk that you should consider. So what was not on the, let's see, what's not on the risk side are the risks of prostate cancer itself and the risk of cardiovascular disease, which has been in the press quite a bit these days. So I'm going to tackle both of these. Okay, prostate cancer is relatively easy because we have no data. Okay, it's really the risk of testosterone treatment in older men, and the risk of prostate cancer is not known. We know that we don't want to be treating individuals with active or metastatic prostate cancer. And we're really concerned about the small percentage of men that have high-grade, really aggressive prostate cancer. But the vast majority of individuals have prostate cancer that's of low grade and probably not of consequence, as much of a consequence in terms of mortality. Okay? And then what do we do about individuals that have been, quote-unquote, treated adequately or cured, quote-unquote, of prostate cancer, low-grade disease? We don't know what the risk is. The main thing, at least in and this is a personal opinion, is that what we don't know is that we don't know what the effect of testosterone is on the natural history of prostate cancer, whether it be high-grade or low-grade disease. And so with that in mind, if you're a conservative clinician like I am, you have to acknowledge that and say, gosh, I'm going to be conservative and maybe I should monitor. There are some people that would argue that in an older population on testosterone, you don't need to be monitoring. And I'm talking about PSA primarily. Testosterone treatment and the risk of cardiovascular disease in older population is also unclear. And what has basically caused an uproar to some extent and concern, at least on the part of some cardiologists that I've talked to, is a paper in the New England Journal of the TOM trial where individuals were treated with testosterone for 6 months or placebo. And actually, these individuals were relatively frail. They had mobility disability, and what that means is they walk slow. And so their muscle strength was probably impaired. And in fact, there were benefits of that. There was improvements in strength and in stair climbing power, at least measured in that study. But the problem is that it was associated with an increased number of cardiovascular adverse events, AEs, okay? And in those individuals, it was 23 versus 7%, but really 7 versus 1 in terms of atherosclerotic types of adverse events. And keep in mind when you interpret the study that the population had a high baseline cardiovascular risk to begin with, and that this was not a planned outcome. It was an adverse event reporting, self-report, basically. There were small numbers, and the dosages of testosterone that were used were purposefully higher than usual because they were trying to get a proof of principle of improvement in muscle strength and muscle power. On the opposite side, in the cardiovascular risk side, there was a similar study in frail elderly men, very similar design, similar kinds of doses of testosterone that did not show increase in cardiovascular adverse events. And the meta-analysis of all the studies of testosterone treatment have not shown that either. So moving on to formulations, I'm not going to say much other than the fact that transdermal and intramuscular are the ones that are primarily used, and it boils down generally to preference. As shown in the slide where I showed prescription rates, transdermal testosterone, particularly gel, has really gone up over time because of its convenience and preference by patients. The thing that I would like you to remember is that as you get older, the clearance of testosterone declines, and so you may need a lower dose. And so it's important to monitor these individuals with levels to make sure they're not getting too high. Finally, monitoring. What monitoring if I decide to treat on testosterone with testosterone in an older population? What should I be doing? Well, I think I want to emphasize that you want to do two things. You want to monitor efficacy as well as safety. So efficacy and safety. And clinical improvement, if it doesn't occur in 6 to 12 months after testosterone treatment and the testosterone levels are adequately increased to normal, you should be asking yourself, do I want to continue this? You should ask the patients, do you want to continue this? Curiously enough, a lot of people say, yeah, I want to continue this, even though they have no clinical improvement. And that's a conundrum that we don't need to deal with in this particular audience, but it does raise a conundrum in the clinic. The safety monitoring, I would argue that the most important period of time to monitor would be early after you start, within 3 to 6 months. And it's not so much that you necessarily are, that this is hard and fast, but what you'd like to know is whether you're altering something early in the course of treatment, okay? And hematocrit, PSA, and digital rectal exams are not an unreasonable thing to do. Now, in terms of PSA monitoring, it's not the same as PSA screening, at least in I know I'm going to get an argument about this. It's not the same as screening because what you're doing is trying to monitor for alteration of the natural history of some underlying condition that's already been there that wasn't clinically detected. And so that's kind of my rationale for, and also the Endocrine Society Guideline Committee rationale for monitoring PSA and digital rectal exam, which is, in my estimation, a little bit less important because it's not really done right anyway and you can't interpret it, but that's an aside. Okay, sorry. But PSA monitoring is not a bad idea, at least early on. And then subsequently, once somebody has been replaced for a year or so, you could argue this is like a normal population. Okay, we've gone them from a low level to a normal level. And now we're talking about something more equivalent to PSA screening. Do you screen these individuals over time? And I have no answer for that either, but at least some people do and some people don't. So the take-home points, and I'm actually quite amazed that I made it through these slides. But anyway, so the take-home points from the talk in terms of the clinical applications of treating older individuals with hypogonadism are that The diagnosis should only be made if you have both signs, symptoms, and consistently low testosterone levels, preferably in the morning. It's not go to a clinic, have one testosterone measured at 5 o'clock in the evening. It's low. Get started on testosterone treatment. It's not that. It's more complicated than that. You should consider the fact that comorbid illness and medications, and potentially, reversible causes of hypogonadism exist. So that before you jump to testosterone treatment, think about those in your clinical management. This is an internal medicine audience. You should be well aware of the complexities of adult medicine, internal medicine, and particularly in an older population. You should be considering all of these and have a more holistic approach anyway. But I just want to emphasize that it's not, again, a simple issue of measuring a level and treating. And before you treat, you need to discuss benefits and risks. It's extremely important to discuss both of those. And to the point where sometimes in a high-risk patient, high risk in terms of maybe they have a family history of prostate cancer, I really go to the extent of actually giving them informed consent and documenting that. You should identify what the patients are interested in treating. It's not always erectile dysfunction, which could be treated with Viagra. It might actually be something more than that. And then finally, in terms of monitoring, you need to monitor both efficacy and safety, and particularly early after you initiate testosterone therapy, within the 3 to 6 month range, and possibly a year. But again, depends on how often you see these folks back. I'd like to acknowledge the host of characters that have been involved, and I've sort of drawn into testosterone in terms of the area, and happy to answer questions. No questions. Thank you.
Al, I have a question for you.
Oh, wait. Where are you?
I'm over here. It seems with millions of older men taking testosterone replacement therapy that we're admitting older men on testosterone therapy to the hospital more and more. And a question has arisen about whether or not we should continue their testosterone therapy in the setting of their acute care hospitalization. As you know, men do worse than women in terms of critical care outcomes and trauma and so forth. And some people have hypothesized that the androgens actually may be harmful in the setting of severe illness. So do you have any insight on this issue?
I have no insight, but I think it's a great question to ask and to study. To tell you
use because their testosterone or continue?
Sure. I think generally you want to try to minimize all medications that aren't necessary to try to concentrate on the acute illness. If you're talking about, I guess the intensivist can actually comment on this, but I don't know of any intensivists that continue testosterone injections or patches or gels or anything like that. Right? And that's more of a making sure that you concentrate on what's more important at the time. I don't think, honestly, to tell you the truth, I'm not sure that there'll be any harm in that, but again, it hasn't been tested. So as you know, you did some studies on recovery from illness, and there may be some benefit there, particularly in the older population, since testosterone levels do fall after acute illness, but what I didn't emphasize, they remain low for quite a while sometimes. And so maybe in that interim of post-hospitalization, there may be some benefit, anabolic benefit, for example, in an older population after surgery for their hip or their knees or whatever, that could be demonstrated at that point in time. It's really unstudied in large studies. Dr. Amory's done it in a small pilot study. Yeah, Steve.
So Al, it's just a wonderful talk. I just wanted, I think your caution was, exceedingly well-founded. I just wanted to emphasize, I think, a point that you made about bias by indication. I mean, I think if we look back to history, and one could criticize some of the pharmacoepidemiologic studies of estrogen replacement therapy in retrospect.
Oh, absolutely.
But there was an enormous body of literature that supported, based on retrospective studies, the benefits of estrogens. And it was only, as you, I think, very clearly pointed out, the experimental trials that showed the hazards. And in the meantime, it became the most widely prescribed prescription drug in the United States, with attendant harms. And I think we've got to be really careful about
I totally agree.
I mean, I think any good pharmacoepidemiologist would say we really can't adjust entirely for bias by indication with those studies as hard as we try.
I'm a good student, I learned that.
Yes, and so I mean, I think I just would re-emphasize that point which you nicely made. I think the question I have is sort of faced with, you know, at least a practice at the VA with, you know, the onslaught of advertising, which you nicely showed. You know, we now have nearly all elderly male patients coming in, you know, having seen this on the internet or on television or on the radio somewhere. And they all seem to meet your criteria for reasons that they may have other causes of low T. What exactly, you know, how exactly what should be the regimen for testing? You know, and besides, you know, I mean, how many times and
at least twice. And then the population that we deal with at the VA, I would measure free testosterone with an accurate free testosterone assay, which we can get into. I didn't get into that, but that's more of something that at the VA I'm pretty confident in because of Dan and Banks and when he was there. You know, it's been validated with a mass spec assay, and the calculation correlates well with equilibrium analysis for all those reasons. But to answer your question, in that population, I would do at least 2 measurements of free testosterone in the morning. And to tell you the truth, you know, what you're going to end up with, the large majority of individuals will be borderline conditions. I took that slide out. That will have sort of minimal symptoms, you know, ED, you know, something like that, whatever. Have borderline low, slightly low, free Ts or total Ts or both. And so you're caught. And so what I would suggest is that I would lower the expectation that you're going to make them better, number one, because most of them don't get better, number two. Number two, I would say we're going to try this for a period of 6 months because most placebo effects will wear off after 6 months. And most people will actually improve initially, but then they'll say it wears off. And say that if there's no real substantial benefit after this period of time, 6 months to a year, then let's stop. And don't feel compelled to continue treating these individuals, right? I mean, it's really called a therapeutic trial, I guess, in the old terms. But I firmly believe that you try to talk them out of it, number one, and just measure it again and follow it over time. But if you are compelled to treat these individuals, I would certainly use a trial and be very clear that I sort of hang the crepe in a sense, is that I say, I don't think this is going to work, but we'll give it a try for 6 months.